A very good evening to one and all present here. I, Dr. Komal Lalwani, welcome you all on the behalf of Nationwide Quality of Care Network to the hand hygiene program entitled Clean Hands Are Safe Hands. The aim of this program is to recognize that people of all levels should work together to influence of safety through clean hands knowledge and behavior. Let me introduce you all about today's agenda. We will start with welcome address by Professor Vikram Datta, followed by the sessions of the day. The first session will be taken by Dr. Ram Chahar on WHO perspective on hand hygiene and its importance in patient care quality and safety. Next session will be on implementation and sustenance of hand hygiene practices in day-to-day clinical practices by Ms. Anju Sehrawat. Then the live demonstration on the same topic will be done by Ms. Preeti Dabas, followed by innovation in implementation of hand hygiene practices by Dr. Surendra Sharma, which will be followed by hand hygiene audit, how to do it session by Ms. Tisha Mary, which will be followed by question and answer session and the vote of thanks by Dr. Praveen Venkatagiri. Now, I would like to introduce Professor Vikram Datta. Professor Vikram Datta is the Director Professor at Department of Neonatology, Lady Hardinge Medical College. Dr. Datta is the Vice President of Nationwide Quality of Care Network, President of Nationwide Quality of Care Network, and Vice President of National Neonatology Forum India. He is a guest editor at BMJ Open Quality South Asia Edition. He is a member of editorial board at International Journal for Quality in Healthcare Communication. He is the expert at the International Society for Quality in Healthcare. He is the lead at National Mentoring Group and Technical Resource Group lead for Sustainable Model of Lakshya by Ministry of Health and Family Welfare India. He is a member of Quality, Equity and Dignity Working Group by Ministry of Health and Family Welfare India. I welcome you, sir, and request you to please take the welcome address for today's session.
Thank you so much, Dr. Komal. Good evening, friends, and a warm welcome to all the participants from Southeast Asia region, and I can see participants from as far as Jordan today in the communities of practice. That speaks volumes about the popularity and the need for such an online communities of practice in this region, aptly supported by the World Health Organization India as well as the Southeast Asia Regional Office of World Health Organization. Friends, I take pleasure in welcoming my colleagues from the World Health Organization India Country Office, Dr. Ram Chahar, my colleagues from the JPIGO, Dr. Surendra Sharma, my colleagues from Bhagwan Mahavir Hospital, Preeti and Ms. Dabal, Anju Sherawat, and also my colleagues from All India Institute of Medical Sciences, Ms. Tisha Mary, and my office colleagues. And very aptly, I would just like to give the full credit for the conceptualization of this program to Ms. Jeena Pradeep and Dr. Prabha Ranjan, governing board members of NQCN, who have short notice have stitched together a program which is going to be very innovative. It's going to talk about implementation science, it's going to have a live demonstration, and it's going to talk about innovations in hand washing. And in the last, we are going to talk about a topic about which we very rarely speak, and that is about hand washing audit, how we could measure the hand washing processes. I would just like to end here and pass on the mic to more apt and able colleagues by mentioning, friends, that nearly 50% of the hospital-acquired sepsis preventable infections can be prevented by performing a good hand washing, and the return on investment from the development partner's point of view is nearly 16 times the investment which you invest in implementing a hand washing process. So you can understand the tremendous return on investment which a hospital team or a peripheral team can get by implementing a hand washing program. So I'm sure that today's program is going to be a great success, and I see nearly 140 participants today, which speaks volumes about the need for this program today. And we are going to be staying connected and invite all of you to continue to be a part of the communities of practice by registering on it and being a part of this endeavor of World Health Organization and NQCN. So thank you so much, and over to Dr. Komal for taking the program forward. Thank you.
Thank you so much, sir. Now, I would like to call upon Dr. Prabha Ranjan to introduce our today's speakers. Over to you, ma'am.
Good evening, all. Okay, good. Thank you, Dr. Komal. Good evening, all. Komal, can you share the introductory slide?
I hope it's visible, ma'am.
Okay.
Yes, it is
Yeah,
there,
yeah.
Dr.
Thank you. Yeah. It's my pleasure to introduce Dr. Ram sir. He is a National Professional Officer, Maternal and Reproductive Health at WHO India. He is a public health professional with rich experience in designing and implementation of programs for maternal and newborn health in resource-constrained environments. He is passionate about implementing quality improvement initiative in public health facilities in India, and he has previously worked with JPIGO as a state program officer for strengthening quality of care of maternal and newborn health services through implementation of safe childbirth checklist. The screen is yours, sir.
Thank you so much, ma'am. And good evening, everyone who has joined in for the session today. Thank you so much, Dr. Vikram, for taking up this opportunity in terms of creating a webinar focused around hand washing practices and taking it up in terms of its relevance in improving the further survival of maternal and newborn case deaths, further improving the maternal and newborn death scenario in the country. Esteemed panelists, it's a pleasure to be a part of the event today. Before we delve upon the specifics of the hand washing, I would like to share, some information or some insight that, a couple of years ago, probably around 5 or 6 years back, that I had an chance to go through. This article, basically compared the trajectories of how the science has developed between the infection prevention and control vis-a-vis anesthesia. Interestingly, if you look at the curves and if you look at how both the specialities have evolved, we can very well see that, over the period of time, since first times the ether was used as an anesthetic, we have seen such an advancement in the way anesthesia as a practice has evolved, probably because there is a direct gain which is measurable and visible both for the patient as well as for the surgeon. However, if we take into account the infection prevention and control, it provides similar kind of dividends as Dr. Vikram just mentioned, but because it is not directly visible and apparent neither to the patient nor to our clinical practitioners, we have not made as much progress in IPC and hand washing as we would have liked. Within public health programs, we consider, and especially when we talk about quality improvement, there are certain practices which we consider sticky practices. The sticky practices are the ones that you need to, be after the healthcare providers. You have to be after them in order to see the improvements. They are not exactly the low hanging fruits, which we can get them to change in a very short span, in a very minimal interventions. So this basically talks about the problems that are associated with both IPC as well as hand washing, if you have to take it up as an intervention or as a specific quality improvement project. According to some latest global estimates, there is a study which says that around 1 million of approximately 4.1 million maternal and newborn deaths per year may be related to the unhygienic birth practices, and that puts a great onus on terms of improving IPC as well as improving the hand washing practices. There is an overwhelming scientific evidence that shows that appropriate hand hygiene is the most important effective action that can help hospitals to prevent the spread of infections, and up to 44% improvements in newborn survivals can be seen when hand washing and clean birthing kits are in place in our labor rooms as well as in our newborn care units. So I think there is a lot of evidence that is available. It's just a matter of time in terms of how we can help with our health workers in improving the practices. Uh, I would also like to share at this point of time that every year, 5th of May is celebrated as World Hand Hygiene Day. And there are themes that WHO run all through the year, every year, which brings focus on improving hand hygiene practices within the hospitals, within the healthcare providers, within the communities, and also provides a number of tools and supportive materials that the communities and the hospitals can work together to improve their practices. Uh, Theme for this year's World Hand Hygiene Day focuses on uniting for safety. Clean your hands. Uh, there is a focus on improving and recognizing that we can add a facilities, climate, or culture of safety and quality through cleaning our hands. If the facility is able to implement infection prevention control practices and improve their hand hygiene practice, this becomes a culture of quality and safety, and this provides direct benefit both for the patients and health workers in terms of feeling protected and cared for when they are coming to the hospitals. Prioritizing hand hygiene at all levels would require interventions not only at the level of clinical practitioners but also amongst the hospital program managers, the clinicians, and the policymakers. Uh, Health workers at all levels and people accessing healthcare facilities need to unite on ensuring that clean hands are the number one priority. In terms of the different recommendations and packages that are available, there is a list of documents that the WHO has created and shared with the global audience, which provide opportunities for the communities and the governments as well as partners how we can work to improve the IPC practices. Uh, just in short, if you have to go for improving the hand hygiene practice, how to go about it. uh, the Wherever, even if it is at the level of health facility or even if it is at the level of community, the recommendations basically talk about developing a multi-model improvement strategy, starting with building the systems. You need to have in place functional toilets. You need to have in place provision of running water and supplies, both in terms of soap as well as alcohol based hand rub, to ensure that there are provisions and supplies available, uh, followed by training and education. That is, teach it. You need to teach what are the different opportunities and moments of hand washing and how to do it. The third part is, and we will be hearing more about it in the session today, monitoring and feedback. That is, check it, how it is happening. The fourth is reminders in the workplace and communication. That is, sell it. You have a practice, you have to perform it, and you have to set reminders at opportune moments, at opportune places, so that the providers are reminded again and again to perform the practice. And finally, the last one, developing a climate of safety and culture of change. That is, live it. Whatever you are practice, you have to imbibe it and perform it in all the environments, in all the places. The most important example that we used to give as part of our trainings is that whatever you are practicing in terms of hand hygiene, you need to practice it outside the hospital environment as well, within your home as well. So if you start doing it, if it becomes internalized, you can definitely bring about a culture of change. And I thank you all for being part of the session today. The campaign theme this year, as I mentioned, is the healthcare quality and safety climate or culture that values hand hygiene and infection prevention and control becomes the paramount for all of us. Let us unite for safety. Let us unite and have cleaning of hands as number one priority in the coming year. I hope everyone will have a good learning experience and knowledge sharing in the session today. Thank you all for being part of the session today. Wishing everyone a good luck. Thank you.
Thank you, sir. Thank you so much, sir. The next speaker for today's event is Ms. Anju Sehrawat. I request Dr. Prabha to please introduce our next speaker.
Okay, Dr. Komal, just let the screen happen. As I'm able to see the screen, I just introduced Anju as I'm working with
Okay, I think there are some technical issues with Dr. Prabha.
no,
So,
I'm Komal.
ma'am, your voice is breaking.
I think Dr. Komal, I
Okay,
will do
some
the
network
introduction
issues
for
there.
Anju. Komal, I will introduce Anju right now,
Okay.
and we can proceed ahead. There's some network issues there. So I take privilege in introducing Miss Anju Sherawat. Anju is a nursing officer at Bhagwan Mahavir Hospital, New Delhi, and she has more than 10 years of experience of working in the labor room. She has done her BSc Nursing and BSc Medical Sciences, along with MSc in Environmental Sciences. A pretty accomplished and a learned professional. She has completed a project on home-based care for diarrhea in Faridabad at the field level. And she's going to be talking about implementation and sustenance of hand washing and hand hygiene practices in day-to-day clinical practices. So over to you, Anju. It's a great pleasure to have you here.
Thank you, sir. Just a minute.
Ma'am, your screen is visible. Please just make it a slideshow.
Just a minute. Just a minute.
Yes. Yes.
Is it visible, ma'am?
Yes.
Please. Okay. Good evening, all. I am Anju Sehrawat, working as a nursing officer at Bhagwan Mahavir Hospital. Thank you, NQOCN team, for giving me the opportunity to share my experience of following hand hygiene practices at our hospital. As all of us know the importance of hand hygiene practices, I will show you how we have implemented hand hygiene practices at our hospital. Step 1. We make sure that everything that is needed for hand washing is available at all the times at the point of care as well as at toilets. And the supplies needed are running tap water, which should be for 24 hours, soap bar, hand wash, hand sanitizer, hand dryer, paper napkins, and towels. Although at hospital we have all the facilities available for hand washing, but sometimes patients ask if there is no soap bar, then what to do? Then we at that time we encourage them, you still have to do the hand washing with plain water, as with this also we can reduce germs on our hand to some extent, so they should do the hand washing. This is the hand washing area for doctors and nurses. Here all the supplies are available, like running tap water, signages in hand washing steps in English as well as in well-known mnemonic, which is in Hindi Suman Ke, soap bar, and dryer. Since COVID-19 has come, we have replaced towel with hand dryer. This is the hand washing facility for patients in wards. At their bedside, they can also, at that time also, they can wash their hand easily, and hand washing steps are also displayed here. This is the picture of the patient toilet area. Here also we have pasted hand washing steps so that patient can revise at the time of hand washing after using toilet. During doctor's round, it is not much easier for doctor to wash hand again and again. So along with file, we used to carry a bottle of sanitizer so that they can use it before and after examining the patients. Sometimes if they forget to use, so we remind them, please use the hand rub. This is the picture showing when to do the hand washing. These are the 5 moments of hand hygiene. Means when we should do the hand washing. At every hand washing area, we have pasted such type of picture in the hospital and along with the hand sanitizer. Step 2 towards the implementation is the availability of educational signages, ISC material at all patient care area. In hand washing area, such type of hand washing step posters are pasted. In wards and washroom also, such type of pictures are pasted, like when to do hand washing for patients, like before eating food, after using toilets, we should wash our hand and to keep our area clean. In corridors also some general awareness posters are pasted, means we should clean our hand and we should keep our health at high. These are also few of the signages which are pasted in corridors or waiting halls and in every possible area of the hospital. Step 3 is the training of the health personnel and repeated demonstration of the steps of hand washing. Training of doctors and nurses. Like it is our hospital protocol to give the orientation training to all the newly joined doctors and nurses regarding the steps of hand washing, so that before starting their job, they know well how to do hand washing. Training of paramedical staff. Paramedical staffs are also given the same training regarding hand hygiene practices. Demonstration to the patients and their relatives. We used to give health talk to the patient and relatives regarding hand hygiene practices at wards, in waiting hall area, to let them know how to do hand wash and when to do. And it is very much important for our health. Step 4, which is the most important one, sustenance of good hand hygiene practices. Once we have implemented the hand hygiene practices, that need to be sustained. Number 1 is the maintenance of training register. At wards, we have maintained a training register in which we keep the record of the personnel whosoever given taken and given training, and we also keep the record of the personnel who means how many times they have correctly shown the hand washing practice. This is the repeated demonstration of step of hand washing, and it's important to health medical and to all medical and paramedical staff, patients and their relatives. This is also most important step towards sustenance. Like it is not possible for everyone to learn at one go, so repeated demonstration is the key to the sustenance. For this, what we have done, like in wards, we 3 staff nurses have taken responsibility to teach the hand hygiene to all our health personnel and including patients and relatives. And in each shift, we are providing such type of training so that someone is teaching someone at each shift. It is very good to learn. Another step to our sustenance is the leaflet distribution, both in Hindi and English. We have kept Xerox copies of hand washing steps in English as well as in Hindi at the nurse station. We freely distribute such type of flyers to the patients and their relatives, and also to people whosoever ask for it to take back, so that at home also they can revise such type of hand washing steps. Another step to our sustenance is the encouragement of paramedical staff to correct and train their colleagues. These are some random pics of our health workers who are practicing hand washing steps, like after eating food and during their free time. It is much easier for them to learn the hand washing steps among their peer groups. Another important step for sustenance is the acknowledgement and appreciation of medical and paramedical staff who follow good hand hygiene practices. I have seen when we teach someone, and if they tell us about how correctly the hand washing step, we acknowledge and appreciate if they correctly show the hand washing practice. And we also used to put their name on the notice board, so that others will also get the motivation that they also have to show such type of practice correctly, so their name can also be on the notice board. Although we are working very hard to implement and sustain such type of practice at our hospital, still we face some of the challenges. Like we have observed, when doctors and nurses are busy, they forget to follow all the steps of hand washing. So this is one of the challenge. And another challenge is skin dryness. So for this, we encourage them to use the moisturizer emulsion, so that their hand will be moistened, and they can get rid of the skin dryness. And the last challenge what we have seen is the poor education of patient and their relatives about hand hygiene practices. As since COVID-19 has come, government has done a lot to create the general awareness among the public to follow the hand hygiene practices. Yet some of the patient and relatives are reluctant to follow this, and they don't follow hand hygiene practices. Thank you.
Thank you so much, ma'am. Now, I request Ms. Tina Pradeep to please introduce our next speaker.
Okay. It's my privilege to introduce the next speaker. We have Ms. Preeti Dabas. She is nursing officer at Bhagwan Mahavir Hospital, New Delhi. She has done her BSc nursing and specialization that is in pediatric nursing. She has more than 2 years of experience of working in labor room and 1 year of teaching experience as clinical instructor at Nightingale Institute, Noida. 1 year teaching experience as nursing tutor at Sharda University also. She has completed a project on effectiveness of distraction techniques on pain intensity during immunization among infants at Ambala, Haryana. So we are privileged to have you, Ms. Preeti Dabas. Session is yours, Preeti. Next 10 minutes, the topic she's going to discuss is live demonstration of hand hygiene practices.
Thank you so much, ma'am. My voice is audible to all?
Yes, you are audible, Preeti.
A very warm good evening to everyone. Thank you, team and QOCN, for giving me opportunity to share how we follow hand hygienic practices in our hospital. So I'm sharing a recorded video in which we also use to educate our hospital staff about hand hygienic practices. Ma'am, can you please share the video?
Yes, ma'am.
कमल वॉइस नहीं है.
मैम मैं अपने शेयर स्क्रीन पे शेयर कर सकती हूँ, मे बी उसमें वॉइस ऑडिबल हो.
Just a minute, let me check it. So I'm playing it again.
Uses these steps. We are using
Yes.
Suman K for hand washing. These are the Suman K steps. And hand washing is done for 40 to 60 seconds, means approximately for 1 minute. And for hand rub, it's 20 to 30 seconds. Okay, so wash your hands and stop the spread. So these are the 5 moments of hand hygiene. First is before touching a patient. Second, before clean and aseptic procedure. Third, after body fluid or exposure risk. Fourth one is after touching a patient. And fifth one is after touching patient surrounding. So in first one, if you are going for any delivering a care, so you have to go for hand washing. Second, before clean and aseptic procedure, like if you are going for any IV medication, cannulization or catheterization, so you have to go for hand washing, then you have to perform your procedure. Third one is after body fluid exposure risk. If you are come in contact with any pus like purulent exudate or body fluids like blood or urine, so you have to go for hand washing. Fourth one is after touching a patient, and fifth one is after touching patient surrounding. You have to remove all the ornaments like ring, any jewelry, you have to remove. Okay, next, first step. Wet hands with water. Then apply soap or liquid hand wash. So first step is palm to palm. Palm to palm 5 times. Each step is done for 5 times. 1, 2, 3, 4, 5. Okay. First step is done. Now second step. Palm over dorsum. 1, 2, 3, 4, 5. Vice versa. 1, 2, 3, 4, 5. Third step is palm to palm with finger interlaced. 1, 2, 3, 4, 5. Fourth step is back to fingers to opposite arms. 1, 2, 3, 4, 5. Vice versa. 1, 2, 3, 4, 5. Fifth step is rotate thumb in palms 5 times. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Next step is rotate finger in palms 5 times. Then wrist. Now your hands are safe. After that, dry your hands. These are the steps of hand washing.
कई बार वैसे गंदे नहीं दिखते हैं लेकिन होते हैं गंदे, तो भी इन्फेक्शन या बेड को हाथ लगाया, गंदे कपड़े को हाथ लगाया, और यहाँ सब जैसे हम लेबर रूम में हम छोटे बच्चों को भी हाथ लगाते हैं, तो बच्चों को हाथ लगाने से पहले हाथ धोना है, खाना खाने से पहले हाथ धोना है, या बाथरूम गए हो हाथ धोना है, कैसे हाथ धोते हैं पता है किसी को? और क्यों धोते हैं? क्यों धोते हैं आप? क्योंकि हाथ गंदे होते हैं, देखने में भी गंदे होते हैं, कई बार देखने में तो वैसे गंदे होते हैं क्योंकि बैक्टीरिया वायरस कुछ भी चिपका होता है जो कीटाणु होते हैं, तो उसके लिए हमें हाथ धोना बहुत जरूरी है।
Now I explained Suman ki steps in Hindi. First, in Suman ki, S stands for सीधा. हम अपने दोनों हाथ को सीधा रखेंगे. सबसे पहले हम क्या करेंगे? सफिशिएंट अमाउंट में हम सोप और लिक्विड हैंड वॉश लगाएंगे. उसके बाद हम क्या करेंगे? बोथ हैंड्स को हम सीधा रखेंगे, आपस में रब करेंगे. This is the first step. Second is U. U stands for उल्टा. हम क्या करेंगे? सबसे पहले क्या करेंगे? पाम ओवर डोर्सम. सबसे पहले इस हाथ को दूसरे हाथ पर लेके जाएंगे और अच्छे से रब करेंगे, ऊपर से लेके नीचे की तरफ अच्छे से रब करेंगे ताकि जो ईच कॉर्नर्स हैं वो क्लीन हो जाए सोप से. देन वाइस वर्सा, हम फिर सेकेंड हैंड पे भी सेम यही प्रोसीजर करेंगे. थर्ड इज उंगलियां. इसके बाद हम जो फिंगर्स हैं उनको आपस में रब और आपस में रगड़ेंगे ताकि कोई भी हमारा जो कॉर्नर है वो ना बचे. सबसे जो भी जर्म्स और वायरस है वो सब क्लीन हो जाए. देन इज उंगलियों के बाद आता है मुट्ठी. हम अपने हाथों को मुट्ठियों की शेप में बनाएंगे और आपस में रब करेंगे. U for उंगलियां and M for मुट्ठी. Next is A. A stands for अंगूठा. हम अंगूठे को अच्छे से रब करेंगे. Next is N. N is for नाखून. हम नाखूनों की अच्छे से सफाई करेंगे. And the last one is K. K stands for कलाई. Means wrist. नेक्स्ट स्टेप हम रिस्ट पे अप्लाई करेंगे. देन यूज वाटर. And now your hands are safe. Now I'm sharing some experience with you all. 2 से 3 मिनट तक मैं कुछ एक्सपीरियंस आप लोगों के साथ शेयर करना चाहूंगी जो कि हैंड हाइजीनिक प्रैक्टिस जैसे पहले फॉलो होती थी और अब जो सिनेरियो है, अब जो क्या क्या चेंजेस आ गए हैं. जैसे कि जब हैंड हाइजीनिक प्रैक्टिसेस पहले बिफोर कि जब अच्छे से फॉलो नहीं होती थी, जब हमें ये लगता था कि हम वो क्वालिटी केयर पेशेंट्स को हम प्रोवाइड नहीं कर पा रहे हैं जो कि हम पहले देना चाहते थे. बट अब और फिर हमने देखा कि पेशेंट्स और अटेंडेंट्स वार्ड्स में हमने देखा कि विदाउट हैंड वॉशिंग, विदाउट हैंड हाइजीन प्रैक्टिसेस वो खाना खाते हैं, केयर करते हैं. और फिर हमने देखा कि समटाइम्स क्या होता था कि ड्यूरिंग राउंड्स एग्जामिन करते टाइम दे फॉरगेट अबाउट यूजिंग हैंड रब और हैंड वॉशिंग. और एक पेशेंट को अटेंड करने के बाद दूसरे पेशेंट को अटेंड करते थे, या फिर कोई प्रोसीजर करने से पहले हम लोग ग्लव्स वियर करने से पहले हाइजीन प्रैक्टिसेस और हैंड वॉशिंग भूल जाते थे. तो अब जो सिनेरियो है दैट इज कंप्लीटली चेंज. ऑल हेल्थ वर्कर्स आर मोर फोकस्ड अबाउट हैंड वॉशिंग और हैंड हाइजीनिक practices. They are performing, they are more careful or attentive, they are following all the steps of hand washing. So इससे क्या हुआ, जो क्रॉस इन्फेक्शंस हैं वो क्रॉस इन्फेक्शन का रेट और जो इन्फेक्शन रेट है वार्ड्स में, हॉस्पिटल्स में, हेल्थ सेक्टर्स में वो डिक्रीज हुआ है. वार्ड्स में जो सर्जिकल साइट इन्फेक्शंस थे वो रिड्यूस हुआ है. और सबसे मेन अब क्या हुआ है कि कोविड आने के बाद जो जनरल पॉपुलेशन को अवेयरनेस हुई है हैंड हाइजीन प्रैक्टिसेस को लेके, उससे क्या फायदा हुआ है कि अब जो वो मोर हमारे जो उन्हें बताते हैं हेल्थ हाइजीन के बारे में, हैंड हाइजीन के बारे में, हैंड हाइजीन और हैंड वॉशिंग के बारे में, तो वो उसे ध्यान मतलब प्रॉपरली हम हमारी बातों को सुनते हैं, अडेप्ट करते हैं, अपनी डेली लिविंग एक्टिविटीज में उन्हें यूज करते हैं, उससे क्या हुआ है कि जैसे कि जैसे आप आई विल गिव यू एग्जांपल ऑफ लेबर रूम कि मदर अपने बेबी की केयर कर रही है या फीड करा रही है, तो उस अगर वो हैंड वॉशिंग करती है तो उससे क्या होता है कि बेबी को जो केयर प्रोवाइड कर रही है उसमें इन्फेक्शन नहीं दे रही है हैंड वॉशिंग प्रैक्टिसेस करने से, या फिर कोई अटेंडेंट अपने पेशेंट के लिए खाना लेके आ रहा है और हैंड हाइजीन प्रैक्टिसेस कर रहा है तो वो भी इन्फेक्शन नहीं दे रहा है। और हमने अब देखा है कि जैसे कोविड के टाइम पे जो हैंड सैनिटाइजर्स है, पहले तो हम हैंड सैनिटाइजर सिर्फ हम हॉस्पिटल्स और हेल्थ सेक्टर्स में यूज होता था, बट नाउ एवरीबडी नो अबाउट हैंड सैनिटाइजर्स, हाउ टू डू इट। अब पहले तो सिर्फ हेल्थ सेक्टर में था, बट अब जो है हर घर में, हर किसी के पास, हर शॉप में दिस आर अवेलेबल। और हम लोगों ने जैसे ट्रेनिंग हैंड वॉशिंग सिर्फ डॉक्टर्स और नर्सेस के लिए नहीं है, दिस इज ऑल्सो फॉर पैरामेडिकल स्टाफ और अदर कोवर्कर्स। अगर हम होलिस्टिक केयर वी आर गोइंग टू प्रोवाइड, सो हमें हैंड वॉशिंग जो है, हैंड वॉशिंग प्रैक्टिसेस है, हैंड हाइजीन है, उसके बारे में सभी को ट्रेनिंग देने से जो चेंजेस आए हैं उन लोगों, और सुमन की जो है, सुमन के मिनिमोनिक से इट्स इजी टू एक्सप्लेन ऑल द स्टेप्स, उस वजह से भी जो इन्फेक्शन रेट जो है वो ग्रेजुअली कम होते हुए हमने देखा है। एंड बीइंग अ हेल्थ केयर वर्कर हमें भी कॉन्फिडेंस और पॉजिटिविटी महसूस होती है कि अपने हाथों को हम साफ करके, हैंड वॉशिंग और हैंड हाइजीनिक प्रैक्टिसेस को हम प्रैक्टिस करके जो इन्फेक्शन कंट्रोल की तरफ हमने एक इम्पॉर्टेंट स्टेप लिया है। एंड वी आर ऑल्सो गेटिंग पॉजिटिव फीडबैक फ्रॉम पेशेंट्स for maintaining cleanliness and following all protocols in practices. So I request everyone to follow hand hygiene practices in order to contribute the improvement of community health. साबुन लगाओ, करो कमाल, 7 कर्म से करो इस्तेमाल, रहो सदा स्वस्थ और खुशहाल. So wash your hands and stop the spread. Thank you so much for listening me.
Thank you so much, ma'am, for the nice information. Now, I request Ms. Reena Pradeep to please introduce our next speaker.
Okay. So we have the next speaker, Dr. Surendra Sharma. Dr. Surendra Sharma is Regional Team Leader, Teaching Impact, Saturation and Epidemic Control, India, Japaigo. Sir is leading multi-state WASH IPC. WASH is Water and Sanitation, and IPC Infection Prevention and Control and Health System Strengthening Projects under USAID grant that spans across 3 states, namely MP, Chandigarh and Jharkhand. Sir is working in the field of public health since 2006 in the areas of immunization, disease surveillance, project management, research management, family planning, and infection prevention and WASH. With a wide exposure of working in different settings, Sir has curated a plan to improve IPC WASH services in resource-constrained setting to march toward global standards. Holder of degree in medical sciences and masters in public health from Harvard University. Sir has published original research articles in peer-reviewed journals and presented at national and international conferences. Sir, we are so delighted to have you here, and over to you, sir.
Thank you so much for a nice introduction. I feel overwhelmed, and thanks to QOCN and Dr. Ram from WHO for giving this opportunity to speak about the work that we are doing. And I was really impressed with the work done by Anjuji and Prithiji in the field, because they are the real stalwarts. So I will just take on from where they stopped and would like to share some of the work that we are doing. And I was also going through some of the questions that were in the chat box, and I would like to address maybe a couple of them during the course of presentation itself. Is my screen visible to everyone?
Yes, Dr. Surendra.
Thank you so much. Yeah. So the overall approach that we employed in Japaigo for any public health issue is that we respond, we create, we execute, and empower. And this has been the tenet for all the work that we have been doing and all the work that we will be doing in going forward. While we witnessed the acute gap in compliance, I think some people were asking the same question in the chat box also, that how do you ensure compliance? We strongly believe in human-centered design approach because we are not robotics and we cannot follow a dictum unless there are some small nudges, some soft power employed towards us to ensure the compliance. Two large-scale projects. One is Dakshata, which were employed in multiple states, and we did some innovative work in Rajasthan and Andhra Pradesh, and this is pre-COVID. And then we also worked under MCGL grant in the three states, Madhya Pradesh, Chhattisgarh, and Jharkhand. And here we focused on hand wash compliance by the healthcare workers. As you can see here, the project Dakshata, when we were doing the external assessment, we found that poor adherence to hygiene compliance in both the states prior to PV examination. It has been known since 1847 when Semmelweis in Vienna mandated that every students and the faculty member in the hospital needs to wash their hands. It's nothing new, but even more than a century and a half later, we are still discussing this issue, because as Dr. Ram was talking about sticky practices, hand washing is definitely one of those sticky practices. Or isko change karna is very difficult. So some of the innovations or maybe, what do I say, project-driven approaches that we have employed was we adapted from the WHO multimodal hand hygiene improvement strategy, which is a five steps approach across 12 facilities, 6 each in Rajasthan and Andhra Pradesh. We assessed the preparedness of the hand hygiene in the first half of the day, and then structured half-day on-site, full-site training for hand hygiene. All the staff members across all the cadres. You can see the photographs from the side, wherein people are sending their responses on the with the sticky notes in the wall, and then everybody is sitting together to discuss the idea of hand hygiene. And I think Preeti was doing an excellent job when she was demonstrating how to do the proper hand wash. Followed by, we focused on developing an ecosystem. As somebody asked the question, how do you ensure hand washing compliance? And if there is no soap, there is no water, there is no alcohol rub, we cannot even think about asking anybody to do hand wash. So we began with that idea. We ensured that there were sufficient supply available for next 6 months for doing the hand rub prior to PV examination at all the point of care sites. More than 300, almost 300 healthcare providers in each of the states was trained. And what we saw, an acute surge in the compliance from 36% at the baseline to 77% in Rajasthan and from 50 to 70% in Andhra Pradesh. As you can see from the graph, wherein we have monitored this activity for 6 months and noted how the compliance has changed. And you can see there's a steady uptake, but that is just one part of the story. Let me come to the next part, wherein we were doing this work in the 3 states of Jharkhand, Madhya Pradesh, and Chhattisgarh. And we were also focusing on hand wash compliance. And this was during the COVID. That was pre-COVID, this is COVID. And even during the COVID, we found that the hand compliance was not that great. Despite the fact that everyone was so sensitive, so sensitized, the hand washing compliance did not show the similar reflection in the field. So what we did, we identified 3 major obstacles to hand hygiene compliance: lack of supplies, including running water, competency or understanding gap in different cadres, and lack of reinforcement. Somebody asked a question in the chat box, and Dr. Ram tried to explain that, and I totally agree with him that periodic nudges from the somebody who may be a peer, who may be a supervisor, who may be somebody working in the same vicinity, or maybe even a visitor. They can always nudge you to ensure that you're washing your hands. Some kind of reinforcement in the form of IEC practices, some posters, some charts which is asking you to wash your hands, may be a useful tool or reminder at the point of care. So what we did, we did training. We ensured the IEC is there, logistic is there. We also tried to use tech modalities here. We all know that India is leading the software development in the world as of now. And Bangalore, our own Silicon Valley, is home to a lot of startups. So we partnered with one of the leading startups from that area, Datacul, who works a lot of image analytics there. What do we mean by image analytics? Image analytics is analyzing the images to find out whether they are meeting certain predefined algorithm. For example, if it's a X-ray and we are comparing that with the predefined algorithm, whether it is meeting the tuberculosis kind of picture. So we use the same technology here, and we said, why don't we create an algorithm which monitors the hand washing steps in the real time and provide the feedback so that anybody who is coming to that particular wash basin gets the real time feedback. I'm happy to report that this AI-based devices were installed atop the wash basin outside the labor room to provide 24/7 real-time feedback on the adherence to WHO steps for hand hygiene. The beauty was that the entire data was anonymous. It was not that Surendra is washing, so Surendra will be displayed, and then Ram is washing, or Preeti is washing. No, it was only focusing on your hands, and it was only looking at whether all the steps were followed in that particular hand wash. And then over the course of the day, how many hand washes were done and how many made the compliance requirement as per defined guidelines. So that this anonymous data will help the facility to gauge their own compliance without revealing person's identity, so also ensuring the security and sanctity. So this anonymous data on frequently missed steps were compiled in dashboards and discussed. Apart from providing the real-time feedback to the person who was washing their hand, the compiled data was shared with the facility in the form of dashboards so that they can decide. For example, I'm just giving you a hypothetical situation. In a particular facility, people stop washing, say, maybe their wrist or maybe their knuckle spaces, and that is the frequently observed the missteps. So the facility can go back to the entire team and talk about those steps. So the average compliance on those steps can be improved, and as a result, overall hand hygiene compliance can be improved in the facility. So these devices were used in addition to a monitoring tool as an aid to training, because anybody who is coming for those training, for example, SBA training, they will be taken to that particular wash basin and they can wash their hands, and then they will see whether what all steps they are missing. I'll show the video in the next slide, and it will become more clearer. And there is a research ongoing on this human-centered design approach using these devices, and preliminary findings are suggesting improvement across all 7 sites. As you can see in the adjoining bar graph, we started in October 2021 collecting this data, and by December, you can see the average bar has increased. The trend line you can see also is on the upper side. So it shows that yes, some improvement has happened, and that improvement has consolidated. You can see the bars are adjoining, bars are remaining on the higher side, and then there are fluctuations, but even then the facility is going back to the better performance going forward. The below graph, the yellow graph that you are seeing is across the 24 hours in a day for a particular facility, how the compliance is improving or decreasing. You can see the highest compliance is just above 50%, and that is around 20,000 hours, 2,000 hours, which is like 8 p.m. in the day. And the lowest compliance you can see is around the early morning, 5 o'clock. Again, this is if you are taking a human approach, it is not possible to watch and document and deliver feedback for each and every hand wash. But the technology is making it possible to document and record all those hand washes, so we can know what is the time frame which require maximum nudges to ensure the compliances. Because the infection is not going to wait for us to intervene. It will get on the first possible opportunity and infect the person who is coming to the facility. Without taking much of time, I think I'm already late in the presentation section. So I will try to minimize the time. So I've taken from the library of all the hand washes which are done over the last 6 months. I just picked 2 examples, one for the bad hand wash and one for the good hand wash. I'll just show the video and it will become clearer to you what I mean by a bad hand wash and what I mean by a good hand wash. You can see here a person is washing, and whatever step they are doing correctly, it is also being displayed on the side. So there is a tab attached to the device which is also nudging them that you need to follow this activity. जैसे हिंदी में आ रहा है हाथ बदले, तो हाथ बदल के दूसरे हाथ को, जो भी थोड़ी देर पहले प्रीति जी बता रही थी, वो सारी बातें यहाँ पे बताई जा रही हैं. And then they are also, if they are not doing those particular activity, then it will be marked as a cross. If they are doing those activity, then it will be created as a green tick. So you can see in this particular hand wash, out of the total 9 steps which we kind of identified, 5 were done, 4 were missed. Average duration was 51 seconds. And then because this score is displayed in front of the person, and if they found the machine is not reading them correctly, because machine is machine, it needs to learn. So if the feedback is wrong, they can always talk to their labor in charge, and then they can go back to the developing team that the feedback is not coming correctly, and they can look into the algorithm, and if the algorithm is wrong, it can be corrected. So this is a good hand wash. As you can see, there is no face visible. So the person who is washing their hand, we cannot identify. So that is ensuring the person's privacy. And these are like auto-recorded video. We did not prompt them that we are recording them, but everybody knew that they are being recorded. So since they are being recorded 24/7, the apprehension to the video also went away once the device was there for 2 to 3 months. Initially, they were apprehensions, but once it became part and parcel of their daily life, people were totally, I should say, aloof to the idea of having a machine washing them all the time. This person followed all those steps. The average time taken was, the total time taken by this person was 74 seconds. And then again, even if that feedback, if she or he found that it was wrong, they can go back to their labor in charge. And this is just one liner that I always use in my presentation, that we need to wash our hands responsibly, but not from our responsibility. The machine will only give you the data. It is us who need to go through the data and take necessary action. Otherwise, the machine is not going to change the practices on their own. Thank you so much, everyone.
Thank you so much, sir. Now I request Ms. Susie Sarah John to please introduce our next speaker. Over to you, ma'am.
Good evening, everyone. It is my delight to now introduce Tisha Mary Thomas, who is working as a nursing officer at All India Institute of Medical Sciences, New Delhi. She has 13 years of experience as a clinical instructor and nursing officer. She has done her MSc Nursing from RAK College of Nursing, University of Delhi, and has acted as a resource person for NICU equipment training for nurses. Over to you, Tisha.
Good evening, respected President Dr. Vikram Datta, Madam Susie, for your kind introduction. Respected panelists and all the delegates present here. First of all, I appreciate MQSM for selecting this hand hygiene as the topic of discussion this month. And I express my sincere gratitude to the resource team for this opportunity. Now, in today's session so far, we have seen the importance of hand hygiene in quality healthcare, its implementations and sustenance in day-to-day clinical practice. Hope I'm audible to all and my screen is visible to all.
Yes, ma'am.
Yes.
Okay, thank you. Now let's see how we can ensure this adherence of healthcare workers in hand hygiene at the clinical settings. So in today's sessions, we will be learning about what is hand hygiene audit, the various terminologies involved in hand hygiene audit, the tools and methods used, observation method of hand hygiene audit in detail, and how to perform the hand hygiene audit. Hand hygiene is one of the most effective means of reducing healthcare associated infections. But studies have shown that on an average, healthcare personnel clean their hands less than half of the times they should do it. So this low adherence to the hand hygiene by healthcare professionals contributes to the spread of healthcare associated infections that affect 1 in 31 of the hospital patients on any given day. So if you define the hand hygiene, again, it's a general term referring to any action of hand cleansing aimed at reducing or inhibiting the growth of microorganisms on hands. Whereas audit is a process which measures the current practices against a defined desired standard. So audit in healthcare is a process used by healthcare professionals to assess, evaluate, and improve care of patients in a systematic way. So if you combine both, hand hygiene audit can be defined as a process of making sure that hand hygiene techniques are being practiced in healthcare settings and follow certain recommended guidelines. Before going to see how the hand hygiene auditing is done, we should know certain terminologies associated with it. The first one of them is hand hygiene compliance. Hand hygiene compliance is a health and safety policy that is required of healthcare providers. This policy helps in reducing incidents of health-related infections, therefore protecting both patient and healthcare workers. अगर हिंदी में बोले, हाथ हाइजीन कंप्लायंस वो है जो हमारा डिजायर्ड हैंड हाइजीन का जो टेक्निक्स और तरीके हैं वो हर एक हेल्थ प्रोफेशनल कितने अच्छे से उसके साथ अधर करके उसको कर रहा है, कितने सही से उस चीज को कर रहा है. That is hand hygiene compliance. So as we have seen earlier, adherence to this hand hygiene is suboptimal in many healthcare settings. So the various barriers associated with low adherence can include the knowledge gap of the healthcare professionals. Healthcare professionals doesn't know the proper technique. They don't have the actual trainings. Time constraints. They are in an emergency. They're running for some work and they don't find it necessary because, as we have said in the initial sessions, the effects of hand hygiene is not clearly visible and measurable. So many a times we forgot to do that. Then sometimes we have myths that our hands and skin integrity get reduced if we do regular and continuous hand washing. Then in certain settings, healthcare facilities, we have less resources. So the healthcare professionals cannot adhere to the regular hand hygiene practices. And there are evidences that absence of role models where they can rely upon. अगर आपके सीनियर्स करते हुए आप नहीं देख लिया या आपको किसी ने बताया नहीं कैसे ठीक तरीके से करना है, तब भी हेल्थ केयर प्रोफेशनल्स वो प्रॉपर हैंड हाइजीन प्रैक्टिसेस नहीं अपना लेता है. These are the certain barriers identified through researchers. So adherence to healthcare, adherence of healthcare workers to hand hygiene guidelines has to be measured. This is very important to ensure adherence to the hand hygiene. So this can be done through direct observation, indirect measurements. Indirect measurements include the usage of soap or hand rubs. हाँ कितना यूज हुआ है उसके तरीके से हम उसको ऑडिटिंग कर सकते हैं. सेल्फ रिपोर्टिंग प्रैक्टिसेस जिसमें वो हेल्थ केयर प्रोफेशनल्स खुद रिपोर्ट कर सकते हैं कि उन्होंने कितना कर रहा है. Then whereas WHO recommends direct observation as a gold standard. Another terminology we will be seeing is healthcare activity, which is a succession of tasks during which the healthcare professional hands touch different types of surfaces like the patient environment, like the linen, IV stands, and each and every such touch is probably a source of infection for the patient as well as healthcare professionals' hands. Now, hand hygiene auditor. An auditor, hand hygiene auditor is a healthcare worker who has had documented hand hygiene training and has experience in auditing procedures. Now let's see indication or moments. In today's webinar, we have many times we have seen the 5 moments of hand wash by WHO. So I'm not going to explain it any further, but we should know what is indication, what is moments. If you see it broadly, indication and moments are used interchangeably. Indication can be defined as the reason why hand hygiene is necessary at a given moment. When we say reason, it should justify the transmission of germs from one surface to another or one person to another. So if you not doing hand hygiene before touching a patient, you are transmitting infection from your hands to the patient. So that is the justification for hand washing at that moment. So the word indication is used in auditing purposes, whereas the term moment is used in common teachings and in public service, public areas like for posters and teaching purposes. Now let's see what is opportunity. Opportunity is the need to perform a hand hygiene. We have seen the moment of, there is an indication for hand wash. Now that becomes an opportunity. When the healthcare professional is being in an indication to do the hand wash or hand hygiene, there is an opportunity for hand hygiene. So there can be single or multiple indications in a single opportunity. How is possible? Suppose in an if we see an example, the healthcare professional is entering in a patient's room to do an aseptic procedure. So if you see the WHO's 5 moments of hand hygiene, the 2 indications or 2 moments are there. But first, before entering the patient environment or before coming in contact with the patient, the first indication. Second indication, before doing an aseptic procedure. So 2 indications are coming together, which makes a single opportunity. So every hand hygiene action must correspond to each opportunity. So when you are auditing and observing a hand hygiene action, so the first responsibility of an auditor is to identify the opportunity in every setting, how many opportunities are there and how many indications are there, whether any indication is missed. If you're not able to distinguish between an opportunity and an indication, then there is a high possibility you are not observing it properly. Now, if you see the importance of hand hygiene audits, we have seen that while easily avoidable acquiring infections during the ordinary course of patient's care remains leading cause of death and disability worldwide, the simplest and most effective solution to prevent such spread of infection is to practice proper hand hygiene. So to ensure this proper hand hygiene techniques or practices are being followed in healthcare settings, we have to do hand hygiene audits. So it ensures the adherence to right hand hygiene practices. Second, it ensures compliance to WHO 5 moments of hand hygiene. Then it can prevent missed opportunities, which I explained already, to identify training gaps. When you see in a particular area, before touching the patient, many staffs are not following that hand hygiene. That could be a reason the staff are not aware that they should do the hand hygiene, because they might be thinking that hands are not visibly soiled, so they need to have a hand hygiene there. So that shows a need for training gap. So to remind the staff of the importance of basic infection control practices. This is how we need hand hygiene audits importance. Now, to make things easier for the healthcare facilities, WHO has developed basic monitoring tools for hand hygiene. So these tools include WHO Hand Hygiene Self-Assessment Framework, which the individual healthcare facilities can use. Then hand hygiene technical reference manuals, which is normally used for training purposes. Direct observation checklist, which is the goal based on the gold standard of direct observation and which is the most commonly used. And this we will be seeing in detail. Then ward infrastructure survey, which gets a survey of the availability of resources, because we have seen it is a barrier that if proper resources are not available at your working place, the staff may not be able to adhere with the proper hand washing techniques. Then the 5th one is soap and hand root consumption survey. This is an indirect method of hand hygiene observation, where through the usage of soap or hand rub or even the paper towels, we assess how much the staff are complying to the hand hygiene techniques. Then hand hygiene knowledge questionnaire for healthcare workers. This is typically filled by the healthcare professionals themselves. This will identify the need for knowledge gaps or training, need for training or further education in hand hygiene for the staff. Now let's see how to perform an hand hygiene audit. This in today we will be just dealing with the hand hygiene audit at the local level. I mean at the ward unit or departmental level. So in this, the first one is communicate with the facility. When we say communicate with the facility, we have to contact the hospital administration before commencing the audit. We should announce a particular period of observation and the purpose of the observation. This should be explained to the healthcare professionals and to the patients as well. Especially from the patients, you need to take formal written permission, because as we have seen from Dr. Surendra Sharma's AI-based hand washing observations techniques are there, but in that the confidentiality is maintained. But when we are doing a direct observation, the confidentiality of the patient as well as the healthcare professional is not able to maintain. So we have to take written permission, especially if we are seeing non-adherence and we need photo-based evidences, then this written permission will be necessary. Observe an individual healthcare worker at a time. This is very important unless you are an experienced auditor or observer, because you may miss certain indications and opportunities if you try to observe different healthcare professionals at a time. But you are an experienced professional, you are observer, you have already done it many times, you are well practiced in it, then you can observe different individual healthcare workers in a single room, or one who is doing the same healthcare activity alongside the main one. First, then we have to follow the 5 moments of hand wash. When you are observing to identify the indications and the moments, you should be thorough with the 5 moments of hand wash, and you should be able to identify the opportunity for hand wash in each and every healthcare activity which is being performed by the healthcare professionals. Document and share key findings, in which we primarily say that the compliance to the hand hygiene should be reported to the healthcare professionals then and there. You need not to give the compliance rate to them, but a formal written documentation should be given to the ward in charge or the IPCC team, or even to the hospital administrator as per the requirements and policies. General recommendations before starting the observation. Now we will see how the observation is done for hand hygiene audit. The observer must be trained in conducting observation analysis as well as familiarized with the auditing process in general. And I think it's clear for everyone. Correct sample size for better results and selection of representative sample for audit. So this is the most important aspect of when we are dealing with the auditing. When we say correct sample for better results, it means that it's necessary for reliability of the result, and it helps in generalization of the data. If you're not taking a correct sample size and a representative sample, then many times our observation may be by chance and does not give us a clear information, because we are already informing the staff that we are doing the observations. So there can be hold-on effects can be there, the biasness can be there, because though the auditor should not be biased and should not give any subjective things, but these things can happen if you are not taking a correct sample. So on an average, according to WHO recommendations, if you are taking a 50-bedded hospital, they should have at least 100 observations when you are doing for analysis. And if you are doing it in a single setting, if you are taking different wards or departments for this observation, then it is better if you take at least 30 observations per ward or per unit, and then you take the complete number of opportunities, complete number of observations before doing the analysis. So this is the basic recommendation for this sample size. Now, by representative sample, we mean the sample should represent the actual ward staff. For example, in a staff, in a ward setting, maybe there will be 50 to 60% or 60% of the staff is nursing staff. And now your representative sample, your observation sample, observation should also be 50 to 60, plus or minus 10 we can take, should be that of the hand hygiene practice by nursing staff. That means a representative sample. You are actually taking observations on the based on the number of staff actually present in the ward. So this way you can establish the reliability of your observation. Now introduce yourself, the auditor, to the observed healthcare professionals and patients as appropriate, and explain your role. Find a convenient place to observe without disturbing the care activities. The observer can move to follow the healthcare professional, but never interfere with their work. So this means when you are doing the observation, you should not disturb the healthcare activity. You should not say anything in between what they are doing. You should observe the presence for any opportunities, and you should just mark what was the hand hygiene action performed by the healthcare professional at that period, at that particular opportunity. And you must see, one observation session should last for at least 20 minutes. We can take it plus or minus 10 minutes. Longer sessions may tire the observer, and in that way you may miss the opportunities. So it is always advisable to keep the sessions for 20 minutes. And in case you can see the end of a healthcare activity by prolonging your observations, because you want to see how that particular health professional is ending that particular activity, and you feel like you can observe it well and fine, then you can continue the session. There is no harm, provided you should not miss any hand hygiene opportunity if you are prolonging the session. Now let's see WHO observation checklist for hand hygiene audit. This is a pre-validated WHO observation checklist, which we can use in our ward settings for hand hygiene audit. So this is the observation form looks like. It has got the header, the first portion, which says the certain details, and in below that the grid is there. The grid explains basic hand hygiene opportunities, what was the indications, and what was the hand hygiene action performed by the healthcare provider at that time. Let's see in detail. How to fill this observation form? You have to, it's always easy to use the pencil and eraser. First, fill the header. This is the header form in which you have to fill the details like the facility name, period number, matlab, on what number that was done, session number, if in a particular observation period, which is starting from Monday to Friday on a particular given day. And the session was first session, Monday, the second session was then, we will write the period number 1, session 2. Then service, what particular service was given at that particular facility, then ward name, department name, city, date time and end time, that each observation period or session starting date, start time and end time. These are the basic details related with each session. Now, indicate any rooms where additional isolation procedures are in place by entering in the comment section. In the comment section, if you are observing the hand hygiene practice from outside the room, because you are observing any isolation procedures, then you have to mention that in the comment section. Use coding system to indicate the type of healthcare provider being observed, because we have said that we have to maintain the privacy of the healthcare professionals. And for better analyzing at the time of analyzing, it's always easy to use coding system. How the coding is done? For example, if the physicians are given a code of A, then the first physician entering in the room will be coded as 1A. Second physician entering the room will be taken as 1B. If you are taking random samples for this procedure, for this observation. Now this is the observation tool where the certain categories are being given. So you have to give the observer ID, that is the auditor's ID, and start time, end time, and these categories. These are the various categories of healthcare professionals you can involve in the observation. Then each column for recording hand hygiene opportunities for one healthcare provider only. Here you will mention in that HCP portion, you will mention the category, here you will mention the coding, that is if it's 1A, then you will code it as 1A, or another is it is 1B. B could be for any social worker or a nursing student. So this can be the way you can code the observations. As soon as observe the first indication for hand hygiene, indications we have already seen many times, the 5 moments of hand washing indicate the hand hygiene action by the healthcare professional. I will show it in the grid how to mention. See, the first moment before the initial contact, patient or environmental contact. Here it's already been highlighted. In the HCP column, we will mention 1A, the coding, the particular coding, and the moment. If you are observing a moment which is before patient contact, the moment 1 of the WHO, before patient or environment touch, you will mark as tick or you will cross. And this is the indication. This 1, 2, 3, and 4 are the indications. So you will mark it at here, and you will see what was the hand hygiene action by the healthcare provider. Whether he has done a hand rub. If they are done just a hand rub, then you will click here. If it's just a hand wash, then you will click here. If they haven't done any kind of activity, that is neither the hand rub nor the hand wash, then you will mark it here missed. This is very important. What the point is, but as you are mentioning what is done by the staff, it is also very important if they have not done it, because that matters when we analyze for the compliance, hand hygiene compliance rate. This missed opportunities matters. So I'm not explaining what moment 1 includes, because Madam Preeti has explained it very beautifully. So I'm not taking more time. So the another example is this is in the grid only. So the moment 2 before aseptic procedure. If you have seen the opportunity or indication for hand wash as before the aseptic procedure being started, then you will mark it here. Then you will mark for whether the hand rub was done, whether hand wash was done, or it was missed. The activity was missed at the beginning. Same with the body fluid exposure. You will mark it here. Then the activity done by the staff. Then 4 and 5 again. The activity done by what was the activity done. Now you can see another portion, that is gloves, bracelets, nails, and rings. These are the certain techniques which you have to mention. If gloves are worn for the procedure, how the hand hygiene, when the hand hygiene was done. If the particular staff is doing the hand hygiene, then the gloves is wearing, then it is a correct hand hygiene method. But instead, if the particular staff was doing a hand hygiene with the gloves in their hands, then you will consider it as a missed opportunity because it's an incorrect method. Then for nails, the proper length of the nails, which is normally considered as 3 to 4 mm. Then whether the bracelets are there, whether the rings are there, if such things are present, though the all procedures was right, but if bracelets and rings were present, then we will consider it as partial adherence to the hand hygiene. So if more than one indication in one opportunity is there, we have already discussed, in one opportunity there can be single indications or multiple indications. Then we have to mark them all. for like this way. In that particular opportunity, there was 2 indications: before entering the patient environment and before the aseptic procedure. The example I have already mentioned, particular staff is entering a room to do aseptic procedure. So the 2 indications are: before entering a room, you are supposed to do hand wash, and before doing the aseptic procedures. So both the indications are clubbed together, becoming one opportunity. So you will market both the indications. General guidelines, use of gloves, I have already mentioned. This non-adherence to correct techniques, which include the presence of nails, bracelets, or the rings. Timing of hand hygiene. Again, if you are not following the...
Tisha, can you make it fast?
Yes, ma'am. Just
yeah.
two more slides only. Then always start with the time and end the session with the end time. Take photographs to support your session. This is the actual grid, which we explained in detail now. This is the compliance calculation. In compliance, we will see how many actions, hand hygiene actions, was actually done by the staff divided by the total opportunities. Opportunities include both the missed and the performed actions, where the activity was actually done into 100. So this gives the compliance rate. This is the grid for compliance calculation, which is given with the observation checklist. This is a method of analysis, like how all methods we can use to analyze for each healthcare provider, and a single indication or different indications for different category of healthcare indications, etc. This is according to the administration requirements. Dispersing our results and feedback, I've already mentioned. If needed, the local action plan can be agreed and implemented at the ward levels with the auditor and the IPCC. So if you see the roles and responsibilities of healthcare professionals, they should cooperate with the auditors, and they should report any deficiencies in trainings, and if they need any training or knowledge gaps identified by themselves, then auditors should be well versed in this practice, and IPCC and the CNE cell should be able to motivate the staff to practice the hand hygiene, and they should be able to identify the knowledge gap. So this way you can ensure the adherence to hand hygiene. This is a research article which is, says how easy to do the hand hygiene techniques if you are doing it, if you want to check the adherence. In this particular study, which was done in 2015 to 16, we have seen that the complete adherence was around 45.5%, partial adherence was 21.17%, and non-adherence rate was 33.3% in a particular public sector hospital. So to summarize, we have seen the terminologies, monitoring tools, and general guidelines, how to fill the observation checklist, and how to calculate the hand hygiene compliance rates. So this is very significant influence on hand hygiene compliance. More emphasis need to be given on compliance with the hand hygiene practices by each category of healthcare providers. Thank you. This is all about my presentation.
Thank you so much, ma'am. Now I request Ms. Gina, ma'am, and Dr. Prabha, ma'am, to please facilitate Q&A session.
So Kamal, can you read out the questions, please?
Yes, ma'am. So the first question we have is from Dr. Manoranjan Mohapatra. He's asking, is it advisable to keep hand dryer in critical areas of hospital?
Can you repeat the question? Is it advisable to
keep hand dryer in critical areas of hospital?
Yes, there are.
Gina, can I answer the question?
Yes, Dr. Prabha.
If the administration provides the hand dryer or the cost of hand dryer, you can anybody can install the hand dryer at all the patient care area or hand washing area. But if the cost of hand dryer is not feasible to accept by the hospital, Then the older methods of drying hands or paper napkins or simply towel, frequently changing the towel, that these things can also work. So hand dryer is a newer thing, and if it is feasible, anybody can use.
Thank you so much, ma'am. The next question we have is that previously the hand washing time was 2 minutes for first hand wash and 20 seconds for in between procedures. So what is the current time now? Dr. Achuma, if you can speak and share your question with us.
Yes. Anybody from the group can answer. If not, we will answer.
Yes, for proper hand washing technique, the total time for each step is 5 seconds. So it comes to 60 seconds. And for follow-up hand hygiene or like while using hand rub, the total time duration is 20 to 30 seconds as explained by Anju and Preeti also. So you can assume that first hand wash should be proper with following all the steps and taking 5 seconds for each step and following suppose before starting the round we should follow all the steps, and then while taking the round we can follow that 20 seconds 20 to 30 second hand rub method.
Surgical hand wash, and before entering to critical areas, 2 minutes hand washing.
Yes, ma'am.
So is it clear? Yeah.
Yes, it's clear. So does anybody have any more questions? The next question we have is, please explain opportunity and indicators for hand washing.
Trisha can answer that question. Yeah.
Ma'am, can you repeat the question, please?
Yes, ma'am. So the question is, please explain opportunity and indication for hand washing.
Okay, definitely. Indication is synonymous with the 5 moments of WHO moments of hand washing. It is the same, but the term we use indication because we use the term audit. In auditing, we use indication. Indication means a reason. And in moments, it is normally used for teaching things, and for public materials, use things like posters and etc. Both are same. When it comes to opportunity, that means for every healthcare activity, there is an opportunity to do the hand wash for the staff. For example, if they are entering a room, there is an opportunity for hand washing. So the indication is before entering the room. The opportunity is they are entering the patient environment. The indication was before entering the patient environment. That is an opportunity for hand wash. It can be before doing an aseptic procedure. It can have an indication and it can be an opportunity. Opportunity is the combined term for indications, which is multiple or single at a single point of time. It can be for one procedure or for combined procedures. I mean, like entering the room, you are touching the doorknob, then it becomes before you are coming in contact with the patient environment. That is indication, and there is an opportunity for doing the hand wash.
Okay, that answers the question.
Yes.
Next question, Dr. Kamal. Yeah.
So I think the next question we have is for Miss Preeti Dabas. The question is, do you use foot operated tape in your hospital setting?
Yes, Preeti can answer that question.
Miss Preeti?
Even Dr. Prabha Ranjan can answer. They are from the same hospital. Dr. Prabha.
Foot operated what? I didn't get the word. Foot operated?
Tape.
Tape.
Operated taps.
Tap.
It's being asked.
Okay, okay.
So
we use elbow operated taps actually.
Okay. So the next question is, which steps of hand wash should be followed, Suman K or WHO?
So anybody is answering, otherwise I can answer it.
Yes, Gina, ma'am, please.
Okay, Suman is just a Hindi version of WHO steps. We are teaching the patients, and this Suman case will remind the healthcare workers like patients or other healthcare workers to remember the steps. S for Sida, just a Hindi version.
May I go take a
Yes,
step?
please,
Sure,
sir.
sure,
Please.
sir.
Thank you. I try to answer this question. Suman K is like easy to remember mnemonic, but the gold standard remains the WHO steps of hand washing, and there is a reason because the process that we follow there are scientifically studied. I don't remember any peer-reviewed article where the both the techniques have been compared, and I would love to see one. But based on my limited understanding, my advice would be to start with Suman K because not everyone is Hindi speaker in this country. So remembering Suman K might not be possible for across the country. So to ensure uniformity, we should stick to WHO protocol. That's my personal submission. And we may begin with Suman K and then finally strive to go for the WHO protocol. What do you?
Thank you, sir. The next question we have is, how many times the staff has told doctors to wash or sanitize hands? What was their reaction? Again, Dr. Prabha, I think you can answer this question.
I think doctors are very aware of the importance of hand hygiene, and they do wash, they do use the hand rub also, but just they forgot. So sometimes they forget to use. So when the sister reminds in our hospital, they never mind. And before and after touching each and every patient, they have to use hand rub along while taking the round. And if any doctor misses that step of hand washing or using hand rub, then sister who is present along with, in the round, she reminds the doctor to use. And I have never came across any doctor getting offended why sister is reminding me. So they work as a team, and no one has reacted.
Thank you. Next question, ma'am.
Thank you
Komal.
so much, ma'am. So that was all the questions we have, and the others have been answered either in the chat and Q&A section by the speakers. So now I request Dr. Praveen Venkatagiri to please conclude the session. Dr. Praveen Venkatagiri is the Secretary of NQC. He's a member of National Mentoring Group by NQCN, and he's the head of NCRI National Network. He is the co-founder of Nucleus EMR and Obam Hospital and Neonatal Care and Research Institute. He has special interest in teams, QI technology, and simulation. Over to you, sir.
Yeah, thanks, Komal, and thanks everyone. It was excellent participation and excellent lectures from you all, sharing your experiences, which was pretty useful. And we had nearly 170 participants, which was excellent. And we sincerely thank WHO represented by Dr. Ram. Thank you so much for giving your insights and supporting the program. And from Japaico team, Dr. Surinder, thank you so much. Thank you so much. And our nursing faculty as well, to everyone, as well as the participants from various places, and our NQCN office for working out this program and supporting this program. I thank, and there are questions about the sharing the PPT. See, the program will be put up on YouTube and also our COP website. You will be able to watch that there. Individually, if any of the speakers would like to share their PPT, we will let you know. You could write to us at NQCN. We request everyone to become the members of NQCN so that we can share our experience and spread the best practices across. Thank you so much. Dr. Vikram, you want to say anything? Yeah, okay. That's fine. We'll close the session as we are, past the time.
Before closing the session, I think we can take the feedback from our participants. So for the feedback, I request you all to either scan this QR code or you can just click on the link which is available in the chat box. This will take just 5 minutes. So I request all the participants to please fill the feedback form.
Komal, we don't have the link in the chat box. Yeah, now
It's there.
Yeah.
Okay, for those who want the certificate of participation for this event, I request you to please click on the link which is available in the chat box or scan this QR code to receive the certificate of participation. Thank you so much everyone for joining this session today.
Thank you, team. Thank you, everyone. Thank you, Dr. Vikram, for organizing the session.
Thank you so much, Dr. Ram, Japaigo, and all the teams.
Thank you. Bye.
Thank you.
Thank you so much.
Yeah.